Welcome to the anatomy of the knee. So, the knee is commonly known as a hinge joint because it allows flexion, extension into this plane of movement. However, it's not a typical hinge joint because it does allow some rotation of the tibia in relation to the femur. So, what is the knee made up of? So, primarily two bones that articulate across each other. The femur, meaning the thigh bone, the tibia, meaning the shin bone. Then we have the fibula, so this lateral bone that sits on the outside. So, the coming together of these two bones, creates what we know as the hinge. This blue material that sits in between these two bones is called a meniscus. And a meniscus we have medial, inside, lateral, outside meniscus. We have ligaments, so we have lateral collateral ligament, medial collateral ligament, ACL and PCL. The purpose of the ligament is to attach bone to provide stability and support around the joint, at the same time allowing for movement. The purpose of the meniscus is to provide some cushion and some support between the joints, and again allow these bones to articulate across each other nicely. Also, what's important to know is we have an additional joint, patellofemoral joint, where the kneecap meets this nice soft surface, I say soft, smooth surface of the knee joint. The patella, the kneecap, is a floating bone, and it's held in by the patellar tendon, or as we know, it's commonly known as the patellar tendon. However, this area here might as well be a patellar ligament. So this patellar tendon, it does attach to the bone, and depending on what literature you read, there may or may not be a break here. So again, patellar tendon stroke patellar ligament, quadricep tendon up here. What we can't see from the anatomical model is the soft tissue that's attached other than ligaments. Is that we have the quadriceps, the muscles sit on the front of the thigh. We have the adductors that attach, some attach below the knee, some attach directly to the femur. We have ITB, so this lateral aspect, again, attaches below the knee. The hamstrings, we have a hamstring that attaches lateral side of the knee. We have two medial hamstrings that attach, again, to the tibia, below the knee. We have the calf complex that sits below it, so gastroc, soleus, plantaris. And again, they attach on the posterior aspect of the knee. And we have popliteal, so the muscle that sits directly in this space here. Their job as a combination or family of muscles is, one, to provide movement, whether that be flexion, extension, or some rotation. Their job also is to provide some stability and some support around this knee, because lots of force is directly placed on this knee through any particular movements. Sit to stand, walking, up and down stairs, and certainly into sports, some more than others. Common injuries of the knee. So we have trauma-based injuries and we have overuse-based injuries. And I suppose we also have age-related wear, and the phrase wear and tear comes up quite often. So let's talk about trauma-based injuries. So in sports, certainly team sports or lots of dynamic movement sports, these ligaments are placed under lots of stress. So if you have a valgus force, so the force that kind of goes from outside and it pushes and opens the inside of your knee, it places this medial ligament under lots of stress and strain. And if the ligament's not quite strong enough or can't control the speed of this movement, then potentially we have some damage to the ligament. Ligament damage is graded 1, 2, 3. 1 meaning up to 25% of the fibres damaged, 2 up to 50%, and 3 the majority of the ligament is damaged, and potentially surgery. So valgus force creates opening and stress on the medial aspects of the inside of your knee. Varus force, so the pressure that goes from the inside of your knee towards the outside, again places stress and stretch on the lateral collateral ligament. Same, graded 1, 2, 3. Unfortunately, common in some sports is ACL, PCL. These ligaments that sit within the knee, their job often is to control rotation. Unfortunately, in football, certainly in football, where the foot gets planted but the body tries to change direction, then the forces, again, that are applied to this, if they're greater than the ability of this ligament to withhold it, then we can have some damage in here. Additionally, because this blue material sits in here, often rotational forces, shearing forces can create some damage to this structure, the meniscus structure. Again, unfortunately, might lead to surgery. Often surgery, though, for these type of issues are pretty successful. When we're dealing with trauma-based injuries, we really have to respect healing time, and we have to respect the process of soft tissue healing, in that we have the inflammatory stage, the proliferation stage, the maturation stage, and then the return, obviously the return to sport. So we basically put you on a continuum, and depending on where you are on this continuum will influence the type of exercises that should be prescribed to you. The knee is a really common place for overuse type problems, certainly in the running community, or again, lots of team sports. And there are lots of different causes for that. One of them may be, so an area of complaint is often this anterior knee area, somewhere around this line here. And like I said, there are lots of different causes. One of them may be, or simply, the tendon's not strong enough, it's not robust enough to deal with the forces or the demands you're trying to place on it. So we would spend time trying to develop some tolerance in this area. Your training load is too much, clearly. Also, the quadriceps that attach to this tendon here, muscles only ever pull in one direction. So these muscles here are pulling up towards the hip. So they're pulling on the tendon, they pull on the patella, the kneecap, and therefore they pull on the patella tendon or ligament. And if that force or that pull is over an extended period of time, or the force is pretty great, then the tendon really struggles to hold onto it, because unfortunately everything's pulling away from the insertion. And in adolescence, then pain along this area here might be termed Osgood Schlatters, and again it's a development issue where there's too great a force on here. Beyond adolescence, we can still have pain symptoms here. We can have inflammatory markers, but all for similar reasons. The quadriceps are too tight, and probably they're too tight because they're struggling with usually eccentric forces, so going downhill when the pressure is very much the load is very much knee biased. That can irritate the knee joint. So again, we try and build up some tolerance of this structure here. Certainly in the eccentric phase, but again, this muscle here, the quadriceps, doesn't work independently of anything else. So it might be an imbalance between quadriceps and hamstrings. It might be an issue further upstream with the hip joint, in that if the hip stabilizes aren't stabilizing, then the next available joint, i.e. the knee, will have to provide some level of stability to compensate for this up here. And again, same goes downstream. If there's issues, certainly mobility issues, with the ankle, then unfortunately the brain will try and escape that and compensate and find a pattern that suits. And the pattern might be another overload here. So lots of these structures, again in particular this area, can be overloaded for many different reasons. So a good assessment would help clear that. Another common area of pain in the overuse category is this lateral knee pain, so pain on the outside of the knee, often slightly below. And again, pending an assessment, potentially it's ITB syndrome type issues, where we have this, again, big thick fibrous band that travels down the outside of our thigh, originates from the hip, inserts in and around the knee. And again, it's an overuse type issue in that your training load is exceeding your ability to cope with it. That's placing, again, excess pressures on these areas of insertion. Often, this lateral knee pain, this ITB syndrome, is a consequence of what's going on higher up. So the inability of your hip to stabilise in particular ranges, to resist particular movements, whilst allowing for locomotion, again, walking, running. To try and reduce the pain here, we would try and develop some strength and stability in these hip abductors, so glute medius, glute minimus, these stabilising tissues. It's a good area to start, but again, in the meantime, to try and reduce pain here, we can desensitise the area through, again, some trigger point therapy higher up. There's real poor evidence, but lots of people like to foam roll this area. Again, it's not really particularly strong advice from me. But again, if we can utilise the capacity or the options available within the hip, we can take so much pressure off the insertions of the areas that attach into the knee.